the theme of this panel follows from some of the commentary during our during the presentation of our findings, and that is, what can we do about the things that we are finding about our mental health system? And we have three individuals here who are doing stuff within our sector. And so to my right, I have Cheryl Forchuk. She is the Beryl and Richard Ivey Research Chair in Aging, Mental Health, Rehabilitation and Recovery, Distinguished University Professor at the University of Western Ontario, and Assistant Director of the Lawson Health Research Institute. And she's going to be presenting on some of her work. Beside Cheryl is Yona Lunsky, an ICES scientist, adjunct scientist, Director of the Azrieli Center for Adult Neurodevelopmental Disabilities and Mental Health. Congratulations, as of last week. That's an amazing development. Senior Scientist in Adult Neurodevelopmental Services and Director of the Healthcare Access Research and Developmental Disabilities HCARD program at CAMH. And we have Simone Vigod, part of our massive team. Simone is Associate Professor in the Department of Psychiatry at the University of Toronto, lead of the Reproductive Life Stages program at Women's College Hospital, and an adjunct scientist at ICES. What we've asked each of these panelists to do is to spend, I think we said, we had a call before, we would say 7 minutes, so maybe I'll pull the Jimmy Kimmel. I'll time you. And if you can be within 7 minutes, you have an ICES pen that has your number. So what they're going to do, just to give you some context, is to describe what it is that they're doing and the research they're doing that is about how we address some of the issues that we are seeing within our data that people are struggling with within the mental health sector. And then we'll open it up for discussion. And we'll also open it up to the idea behind this is how do we address problems within our sector, and how do we get evidence into action? And just as a bit of background, and how do we, and Cheryl came up to me afterwards and told me that, you know, this restraint reduction is really great, but there's actually an NFB, a National Film Board documentary about a Hamilton psychiatric hospital for 150 years had 0 mechanical restraints. So the other piece is, how do we incorporate history? How do we learn from the past? How do we learn from the present? And how do we be more systematic in applying evidence to what we do day to day? So I'll turn it over to Cheryl first to describe her body of research as it relates to today's topic.
Thank you. Very happy to be here. In addition to that, my background is a psychiatric nurse, and I like to think that I am a practitioner in research clothing. So I'm really interested in change involving people with lived experience, with frontline workers, to identify what are the structural issues that get in the way, how can we create change. Once we test it on a smaller basis, how do we spread that out to multiple sites. I'm going to focus particularly on the transitional discharge model because we have a long history of evidence. This takes place in many countries on the world now. But originally, when that model was developed, it was in relation to when I did work at the old Hamilton Psych, which had the shortest length of stay of all the provincial hospitals at that time of 21 days. We had one ward where people had to be hospitalized 5 years to get onto the ward. We did that. We did a participatory action project with the people on the ward, the staff, and they came up with a model that basically talked about requiring a safety net of relationships to move from hospital to community. I would say when we started that project, you had a better chance getting off the ward by death than by discharge, and all 38 patients were discharged with only 2 brief readmissions. The safety net of relationships involves a combination of overlapping staff, so that the inpatient staff continue to see the person until there's a therapeutic relationship established with the community care provider plus peer support. So this provides a safety net of relationships. That was good, but we didn't know this was an unusual ward. So one of the next studies we did, we had 26 wards involved, 13 pairs that we matched. For similar length of stay, they were within half day. We had over 40 wards volunteer, but we've only matched similar wards and literally flipped a coin. 13 wards implemented the intervention, 13 wards business as usual. Although they're half day, and they're all tertiary care wards, half day difference in length of stay at the beginning. Once we implemented, there was a 116-day difference in length of stay. Basically going from 6 months to 6 weeks, admissions in tertiary care. We've had, that was published back in 2005. We've had multiple, repeated success. Hundreds of places, as I say, have implemented this, but not everywhere in Ontario, despite this being a made in Ontario solution. Back in 2006, the Scottish Parliament declared this a best practice because of the dramatic reduction in readmissions in Scotland. CAMH, we worked with the project, just finished up a couple of years ago with 9 hospitals, and again, one of the differences here, we were incorporating acute care wards, and within 2 months of implementing the model, we saw a reduction in length of stay, and we're still working through some of the ICES data to see if what we were hearing from focus groups about the same thing we found in the past, reduction in readmissions also take place. But it's very much about relational care, and the thing we must keep in mind that in mental health as well as mental illness, and those two things are not synonymous, transitions are always important. Transitions are a period of potential growth and recovery. They're also a time of risk. I've also do a lot of work around housing, preventing discharge to homelessness, other things we don't have time to talk about today, but it's always the same kind of process. But the key takeaway is around relationships, peer support, as well as the overlapping bridging staff.
Thank you. So we've got transitions in care being systematically evaluated with the conceptual framework of the sort of the relational aspect of this, and rigorous evidence developed with a little thing about it being more widely adopted outside of Ontario than within. That's something we might follow up on. Okay, Yona?
So I guess similar to you, Cheryl, I'm a psychologist by training, and my very first job in Toronto was working in then what was sort of thought of as a bit of a backward kind of inpatient setting for adults with developmental disabilities and psychiatric issues. So I sort of was seeing things as well, maybe seeing some of the problems. But we didn't have any data at all actually to understand what was going on in terms of hospitals. And so the first thing that I got involved in was working with, for people who remember the CAPS data set, which was looking at the former psychiatric hospitals. And we just asked a simple question, because they did capture it, who had a developmental disability diagnosis and all that outpatient and inpatient data. And I came to this not as a health services researcher, but it was so evident when you started to be able to look at it that this is actually a sizable population, both in the hospital and also in outpatient settings. But I think what helped us get to the program that I direct now, the HCARD program, which is using provincial data from across the province of people with developmental disabilities in adulthood. And it came about through linking data that we had through ICES, our health data, but also working really closely with our partners at MHASEF to get information around who was a recipient of ODSP with a developmental disability diagnosis. I think we only got to that project, not because of the admin data that we looked at from the CAPS project on the hospitals, but because we made the information meaningful from that earlier sort of psychiatric hospital study. We worked very closely just explaining what we learned from the data with the stakeholders in each of the 9 regions of the province where those hospitals were to figure out what does that information mean? What do we do with it? What are some directions? And we just sort of kept those relationships up, I think, sort of leading eventually to the project where we were able to link data and study things more broadly. And again, it was the same kind of story with HCARD, I think, where once we were able to link the data, first of all, we discovered that people with developmental disabilities that we could identify using health data, and people with developmental disabilities that we could identify using social services data were actually not all the same people. I see Betty Lynn smiling because she was leading that actual work where we showed that a third of people would only be identified through one data source. So this idea of data linkage was really important, and kind of helping people understand what we learn when we go through this whole extensive trust engagement exercise to link data, kind of what that means and why it's so important. And then again, we weren't focused with HCARD in looking at mental health and addiction issues, actually. We were looking at primary care initially. But the mental health and addiction issues was a huge piece of what we were finding out. So I think maybe the other lesson was, again, when you start to look for it in the data and when you try to use indicators that are similar to sort of the language being spoken by other people. So, it's not a coincidence that we've also been looking at ALC data, repeat admissions data, repeat ED visits data, but specifically in people with developmental disabilities. If we can say, okay, we have the story of this, really complicated, difficult situation in our hospital, we also have the numbers for your LIN of how often that seemed to happen in 2009, 2010, or we have that information going on right now, 2014, 2015, for the whole province, or for this age group. If we can have the same language, I think that's really helpful for making things shift. And then maybe the last point I want to make is that, Paul, you said earlier today that it's only a baseline if we respond to it, right? So part of what we've been doing with each card is not just sort of getting our indicators or getting our numbers and helping people understand what those numbers mean, but sort of saying, well, what is next? What do we do with that, right? So in Arlen, through the Acute Care Alliance, for example, we're kind of saying, well, we know that we have high rates of ALC for adults with developmental disabilities. We know that we have higher rates of repeat emerge visits and repeat hospitalizations. It's again about that transition, right, into care and out of hospital. So what can we actually do on the ground with the people who are working in those hospitals and in the community to try to figure out how to get at that issue? So eventually where we'll go, hopefully, is we can look at our data and see a different story, 5 years from now, that kind of thing. But right now it's actually just using the information to figure out kind of what are the sort of levers or the opportunities that we have to change things. And it has to involve stakeholders, not just administrators, but also people with lived experience and families and people really struggling in the community to sort of make people's needs met. So it's a slow process, but a really interesting one.
So if I could summarize there, so you're talking a little bit about what we feel like we do in the Mental Health Foundation program, which is advocacy through data. So that's the one piece. And that in order to do that effectively, you've been very strategic and diligent about the relationship development piece with a bunch of different sectors, and then moving on, it's the next steps. What do you do with that? Okay, Simone?
So my name is Simone Vigod. I'm a psychiatrist, and I run a women's mental health program at Women's College Hospital in Toronto. And the specific program that I run focuses on women who are having issues related to their mental health at around reproductive life stages. So that includes women who are struggling with issues around the menstrual cycle, issues around pregnancy and postpartum, and issues in the transition to menopause. So there really is a theme of transitions across this panel, but I think what ties it all together is really being thoughtful about how do we, I loved what Dr. Kurdyak said earlier, is we can measure all of these disparities and we can start to understand them, but at some point we have to turn our attention to responding to them. And so my example is to talk a little bit about a population that we have yet to talk about specifically today, although it relates to adult mental health and relates to the mental health of women who make up 50% of our population. So my focus is on understanding and undertaking initiatives to improve access and acceptability of care for pregnant and postpartum women with mental illness. And what I'm going to talk to you today is about the part of my work that includes developing and evaluating a suite of interventions that leverage digital and other innovative technologies to achieve the goal of improving access and acceptability. So I thought what I would do is spend my 7 minutes, of which probably a minute I've already used, talking to you about what drives my overall vision and goal for this program, the questions that drive my research focus, some of the initiatives that my team's been undertaking, but also to raise some of the challenges that I'm facing and that I would really wonder about others in the audience or on the panel are facing in relation to how we actually then use the knowledge that we build in research to improve the health of our population. So why is this important? Mental illness affects about 20% of pregnant and postpartum women. When untreated, mental illness is going to have an impact on the health of these women. The longer we leave their mental illness untreated, the longer it is going to go on and become a chronic disorder. This isn't, people don't just get better from pregnancy and postpartum mental illness and then never get sick again. And then there's also a direct impact on the health and developmental trajectories of a child. And I'm always struck around the advocacy that is occurring in this province around child and youth mental health. It's absolutely wonderful, but I'm always struck about the fact that women and parents and mothers will advocate for their children in a way that they will not advocate for themselves. And in fact, we have 30, 40 years of evidence to know that if we make a parent well, if we treat the mom, her child's outcomes will be better. And yet we're a little bit splintered around this. So I'm pleased to get an opportunity to talk about this today, because I would argue that we need to think about child and youth mental health even before that child is born. Amazingly, we don't actually need to develop new treatments to manage maternal mental illness. So for women who have mild symptoms of mental illness in pregnancy and postpartum, we know that psychosocial treatments work. We know that peer support works. We know that support groups work. We know that even exercise works. We know that increasing support, like just getting a break, works. For women with more moderate severity symptoms, we know that psychotherapy works, whether one-on-one or in group, to help around the transition to parenthood. And although medications don't work perfectly when women have more severe illness and when psychotherapies alone aren't enough, we know that medication can be helpful. So we have a lot of treatments that work. But what's the problem? The problem is, after everything you've seen today, that you probably wouldn't be surprised to know that only 1 in 5 women, and this is not just in Ontario, it's not just in Canada, it's actually, this is a problem in most developed countries, only 1 in 5 women receive care to remit their depression or their anxiety disorder in pregnancy and postpartum. There are multiple reasons for this. Some of this still has to do with stigma and lack of knowledge, but a large part of this has to do with the fact that we are not getting the services to the people who need them. As I'm going to repeat again, we're not aligning the intensity of the service to the intensity of need. And so, are there specific, some of the barriers are barriers that are relevant across the board in the adult and child mental health sector to access. There is a lack of regionally available specialty services, especially in perinatal mental health, where we need to be thinking about how specifically we are targeting the psychological issues in the transition to parenthood, when we're thinking about how we use medications in pregnancy and lactation. So there are some issues with specialized services. But if you can also imagine you're a pregnant woman who's about to go on leave, you have to get in your hours before EI, how does that allow you to take half a day off every week to go and get your psychotherapy, even if you could get it? If you are a new mom and you're not sleeping at night and you have 3 other children to take care of and you don't know when your baby's going to nap, how exactly are you going to come and get the care that you require? The women who come into my office are not women who are unable to take care of their children. They're in fact putting their children's needs first, but they are certainly suffering. So, where does that lead us? So, to combat some of these barriers, my team has been looking a lot at how we can leverage digital technology. So, women of reproductive age they're online, they're in Facebook groups, they're accessing things online, and what we've tried to do is develop interventions for each level of need, and we've also started to try and develop digital interventions to try to capture people who otherwise wouldn't come into the system. And what's been, so we've been doing things, we have a postpartum depression app that's been launched all over Canada that women can download onto their iPhones and essentially screen themselves, and then they're given information about services in their areas. We launched in April 2017, we've already had 600 women sign up for this, and in fact 300 of them, we're doing a sub-research study associated with it. 300 of them have actually given us genetic samples that we can test to see if we can look at the reasons why this is happening. But the service use part is, can we find women who otherwise aren't coming through our system? At Women's, we developed an online postpartum support group, again, an evidence-based intervention, but we do it online and it's a closed group, so women don't have to be at a certain place at a certain time. We tried to do live chats, but women said, forget it, we don't want live chats. We want to be able to log in at 3 o'clock in the morning and leave our post and then have someone else leave a post, right? So we've been working with that intervention. We've been working with the Ontario Telemedicine Network to deliver video visits direct to women's homes. So I don't know how many people have used telemedicine, but traditionally telemedicine in Ontario has been, in the north, let's say you have to go into your family doctor's office and you sit in this big room, and then you're connected to a doctor in a downtown Toronto center. So that's not going to work in this population. So we're actually using video visits direct to people's home. They can download the Ontario Telemedicine software directly to their phones and use it. We're doing a similar thing for psychiatric care. And we also developed an online interactive patient decision tool that can help women understand about the use of medications during this time period, et cetera. So we've actually gotten funding to develop and evaluate each of these interventions, and some of them are at different various phases. And it's really, really exciting because when we put out ads for these, we get people signed up for the Mother Matters trial that we did. So 50% of the women had to agree to wait 10 weeks before they started their group. We recruited 100 women just in Ontario in like 6 weeks. So it just shows the demand that's out there for these. But I think the things that I'm struggling with most now are, where does it go from here? So I'm trained in research. I'm trained in how to do a randomized control trial. And we're actually going to have evidence, and some of this stuff like our online patient decision tool went through mounds and mounds of changes before we could get it to work, right? So it's not like you just develop these things and give them out to people and then they work, right? It's mounds and mounds of evaluation and change, and I'm so stuck now with where does it go from here? So we're going to develop all these things that work really, really well, and then how are we going to take them to the next level? And how are we going to manage the disconnect between like non-research services or relationships with policy to say, like, now we have something that worked and we figured out how it's going to work, and we figured out the economics around it. How do we get from there to implementation? So that coming from my angle, like how do we get there so that we can actually use the system? And then coming from the community angle and all frontline people who are delivering interventions, how do they get the skills to do what we can do in the research angle, which is how do we know if this is working, and if it's not working, how do we need to change it to make it to work? So I'm really interested in this concept of, we've identified what's wrong with the system, we've identified some solutions, we've suggested them, how do we bring it back around and actually implement it into the system? So I'm sorry if I used slightly over my 7 minutes, but I wanted to just get that out there for discussion.
Okay, so 2 points. I think Yona may have won that ICES pen, so congratulations, Yona. Second is that you said, Simone, you said that 50% of the population is women, but I want to point out that 75% of this panel is women, and that's no accident. So take that, Justin Trudeau. Lots of amazing work that Simone talked about, which is identifying a problem and then really developing innovative solutions to do it. But I think at this point, the themes that come through are that there is this sort of relational issue that is happening across all. There's this struggling with transitions in light of people leaving hospital into another sector, people being identified through various ministries, not being represented by one area, focus on the child's care when the mother's needs might be systematically overlooked by the structural care that's being provided. And then the final piece that I want to open it up for is something that David Naylor has said over and over again, that Canada is a land of pilot studies. And how do we get from evidence that is generated, adopted in Scotland but not Ontario, evidence that's generated and ready to go, so what do you feel in your various levels of experience in different realms, what's stopping that from happening? And all the microphones are off.
Well, I'll speak to that first. One of the issues that we often have, and I think from all these examples, is that you cannot solve the problem totally within the mental health system. It crosses sectors, and so that increases the complexity. We actually have had good luck, in terms of having many hospitals in Ontario adopt for example, the transitional discharge model. Part of it is because of using participatory action research. We have the hospital administration, the frontline workers, et cetera, involved in the research from the start. And because we're using the hospital data at the hospital and getting monthly, they're giving us the data monthly, but then they're also seeing the data. So that helps. So usually once we've gone in for a study, things continue. After, the issue is more spreading to other hospitals beyond that. One of the challenges with that as well is because it's out there in the literature, many times people will say, oh, I've adopted your model, I read it, it's really great, we've adopted it. The only thing though, we didn't do the peer support. We adopted it, but we just are doing the bridging staff. And so they're not actually fully implementing the model. And they're not telling us about it. We have all kinds of, one of the things we find helpful is we always develop toolkits regardless of what intervention we come up with. So we don't just have the publication out there. We've got a lot of toolkits that people can use. And so if they don't contact us, they're basically just going from that very short research article that really does not give the fine level of detail for implementation. The purpose of a research article is to give the evidence as to why it works. It's not to say how to implement it. And so then we end up with a gap. I can't tell you the number of times I've gone to a conference, I've gone into a session on transitional discharge, and I had no idea those 3 hospitals had implemented it. They never contacted me, and they could have had a much easier time of implementing if they had.
So I think another barrier has to do with both the communication back from, say, the hospital or the site that might be involved in doing something, but also I think when we're working with policy, whether it's working with an individual LIN or working sort of at the corporate level with ministries, is that their job sometimes is to change, right? Their job is to either move to a different part of that same setting or a different portfolio. That's how government works sometimes. My job as a researcher is to be incredibly narrow and keep doing the same thing for a really long time and get really good at it. I'm not really that narrow, but so I think that difference though is important, because I think sometimes as a researcher you might get really frustrated. Well, I did all this work and now they're gone. They just switched, or they're no longer in this job, and now nobody knows what I'm talking about. So that's in a sense a barrier. But I think if you understand that's actually the nature of the beast, so you have to be able to figure out how to say exactly what's important in the right language, quite quickly, and have kind of thick skin and not get super offended about the fact that people have switched, because they're always going to switch, right? But that I think is a definite barrier. And I think also the owning of it from the practice side. If people don't really know, for example, you might have this awesome toolkit, but if people don't necessarily know what the whole toolkit is because they only found the one piece and it's not connected well, or it's just that one extra step of communication to know how to use it, and everyone's short on time and they maybe don't realize how nice and approachable you and your team is, or the kind of thing that you're doing, then maybe they don't always go to use. There's got to be a real sort of transparent, not just available, but actually working on those relationships, knowing that even people in practice will change over time, right? And I think the other group that we sometimes forget to engage in it, and it's the group who cares about it the most in a way, are the people, with the issue and their families, right? So it's not just sometimes, again, that sort of individual person. I think in each of the projects we've been talking about, it really affects more than one person. But how are we sharing that information in a way that's useful to them, so they know about it, so they can help to keep those things being used and being used more consistently sort of across. So it's not just one little group doing it with not a lot of power to do it because they're pretty stressed and there's a lot going on, but kind of that consistency.
So I think one of the things that Dr. Forchuk brought up is really important in my field is that there is this cross-sectoral management. So so public health and the Healthy Babies, Healthy Children's program, where public health nurses there's actually an amazing system in Ontario for public health nurses to assess women who've just had a child, for example, and then to determine if there's a problem. But if you look at the Registered Nurses Association of Ontario guidelines, that's actually where it stops, because it's within the scope of the nursing guidelines to provide support, to provide supportive listening, which is going to be sufficient for women with a certain level of need. But then the problem is, it cuts there. And when they need to get into the health system to have treatment for a mental disorder, again, separating mental health from actually having a mental disorder, there's a disconnect. And I'm going to be a little bit controversial here to say that I think as a researcher, part of the issue is that how do I sit at the right table to have the right people hear like what I think or what I've evidenced or what I've researched about how we start to bridge that gap. And sometimes, from the perspective of a frontline clinical provider, what it looks like to me is that a certain program might get implemented in the community and resources might get spent on it, but I don't actually, it doesn't even have face sort of validity to me about what's going on with my patients, nor is there any evidence behind it, but money is being spent on it, nor is it getting evaluated, and I don't have an understanding, either as a clinician or as a researcher, like why that's happening, at what level changes get affected. So what I would say is, although it's not, I think it's more about not getting offended about that, it's actually about really thinking about how we shift our systems a little bit in terms of the communications between government, policymakers, clinicians, researchers, people with lived experience to align like the problems with the solutions and the evidence, because I think maybe we are not being efficient with our resources, and if there was a better system, I just think we could do better, and I don't have all the answers to that, but those are just my reflections from the hats that I wear.
So one of the things that I've started, and I think this is going to pick up on a different theme, is that at CAMH, for example, we have a first episode program. So it's like there are structures in place. So if you want to do something to address quality of care in first episode, it's still hard, but the population's there. You can concentrate the resources. Whereas if somebody comes to CAMH with a depression, that individual may get treated for the depression in about 5, 10, 15 different sectors of our organization. And so the job of standardization and adhering to evidence is very, very different in those two circumstances. And this kind of theme came up in all of your presentations. So what do we do about what are potential solutions? And this, you can respond and then maybe it's time to open it up. But to me, that is the biggest struggle, is that we can't slice and dice our clinical populations, our community populations to the nth degree to align services to particular populations, because that's just completely inefficient. But we can figure out ways to provide systematic care for these populations when and where they are, but it's proven to be quite daunting. So to me, and I think that's kind of where you were going specifically, Simone, but it's there in everything you're talking about. So in your implementation efforts, what kind of things have you found to work to address this kind of non-siloed nature of clinical populations? Okay, so I do have this tendency to ask questions that kill conversations.
I think having the right stakeholders around the table is one key thing that's really important, and I'm glad you did emphasize the consumer perspective. And in terms of advocacy, we actually find that consumer groups have been some of our best advocates. The other thing I think we don't pay enough attention to in a lot of our clinical interventions is to also building on your point, that the context really matters. And so a solution that may work in downtown Toronto may not work in Owen Sound, and vice versa. And so I think that this piece, when we're talking about evidence-based approaches, it always, and you're saying even within CAMH, which program you're on, but it's much broader if you're thinking about the province, and certainly even with our intervention, like if it's an urban versus rural area, how does the peer support happen if there's no public transportation in a rural area, where we find that there's much greater emphasis on phones, for example, Whereas in an urban area, there's transportation, but in a tight budget, where someone has limited money, the phone might be something that they're going to give up earlier, but not in a rural. So how things unfold in those contexts, because of those different contexts, is going to look quite different. So how, and just as one concrete example, one of the things, we like to use a combination of data for any of our interventions where we do focus groups very early on intervention to pay attention to those contextual issues. And in our technology work, in particular, we also always include an ethical analysis. So again, the data is really important, but we have to be thinking very broadly, what is the data? The data is not just those numbers issues, it's also those contextual pieces that you need to tease out in a different way. And as I say, I think sometimes it's not just a matter of does something work, but is it actually the right thing to do in terms of standard ethical principles. And so I think that we have to be looking at things very broadly and looking at through these multiple lenses.
I think that's true. I think we have a lot to learn from the design literature outside of medicine and outside of healthcare about conceptually, the things that have to be part of an intervention, that are the necessary pieces and need to be done in a certain way, and then the set of things that are modifiable and need to be modified to the context. So I think that's actually a really, really important point for how we figure out how to do things. No, we can't slice and dice the population, but we have to make sure that people get the appropriate care. And I think, Dr. Kurdyak mentioned some of the work we did around schizophrenia and how actually seeing a physician was helpful. And what's really interesting to me is that the main helpful for readmission, that the main determinant of readmission probably relates to medication discontinuation. When we looked at the same populations with mood disorders, with depression, with bipolar disorder, we don't see as large or even sometimes any effect of seeing a physician, or even looking at do physician visits after going to an emergency department for a self-harm attempt. Does that make a difference? And it really might be because the actual interventions that are being delivered aren't actually the interventions that work for people, right? If you have severe suicidality and are struggling with your emotion regulation, and then you go and see your family doctor who doesn't actually have, nor should they have, the training in dialectical behavior therapy to help you manage that, then probably seeing a physician isn't going to be there. So I do think we don't need to slice and dice, but we could probably be better about checking in on what's happening to people, aligning our services. I don't know if maybe we could talk about the concept of increasing access to psychological services and what Ontario maybe is going to be doing about that.
I think just to add one small thing, it's almost like you're talking about kind of what is maybe key things that could happen across a number of populations, but then flagging when actually this is quite unique. So for schizophrenia, this piece around the physician makes a difference in a way that it doesn't for this other group. So with developmental disabilities, for example, in the emergency department, when we end up engaging with emergency departments, we see that actually they're doing a lot of this work already with the geriatric population. But the issue is that when someone comes in with dementia, who's fallen and who's confused, everybody knows what to do because they look like they're 80 and they have a protocol they've memorized. Well, I can say, well, here's the protocol you need to follow for this population. We can have a million different protocols. But if many of the steps are the same, there's just this one extra tweak. So if they look younger, but they also have a cognitive limitation, you need to just apply what you already know, but just add this one ingredient. That's kind of easier for people to learn. And it reduces the number of different protocols we have to have for different groups.
So just to add to what you're saying and to build on what I'm saying about context, what we find is important is the principles need to remain steady across context. The same principles apply. Like, for example, that you have to have your medication renewed within a certain period. But the strategies are to achieve the principle is what can vary by context. So for example, principle of peer support is important regardless if you're urban, rural, how far apart. But the strategy, whether that's going to be phone-based or in person or in a group or in individual, can vary. And I think that very often we mix up our strategies and our principles. And it's the principles that are less flexible, that have to be in place, and the strategies are more contextual.
That's so the implementation versus the evidence is such a divide. I'm going to open it up to see if anybody has any comments or questions, and then I'll also check in because we have a bunch of people participating by webinar. If any comments have flooded in. First of all, from the audience, anybody have any thoughts or reflections on what's been discussed so far?
Astrid Gutman from ICES. So I think some of what you're talking about in terms of bringing the evidence to the field and where do you need policymakers versus, where do you just need a field that's a little bit more organized and has some support from data people. Guys, you think about all of the evidence around learning health systems, right? And I think there's a lot that can be done by, organizing. If you have a table of all the emergency, if your issue where you have good evidence on, how to improve care for those, adults with developmental disabilities and mental health comorbidities around their emergency department, you need to be able to, have an engaged group of emergency departments who, sit and, and work together. And I think I don't think you always need policymakers at the table, and I don't think resources are always nice, but there are ways, I think, to move that, but you need people in the field who are really committed, and then as researchers, you need to be kind of engaging with them because you're not going to be the ones implementing it all, they will be. So I think that concept, and there are a lot of really nice examples, I think, from certainly from the US, a little bit from here around the sort of learning health system. And then my only other comment, but maybe the policymakers in the room can talk about that too, this notion that, the person in that position has moved on and then all is lost, it really shouldn't be that, right? It should be about institutions that work together, some governance around how does a research community, not an individual researcher and an individual person who happens to have a role right now in a ministry work. And I think there's some very nice examples of, how that governance works. We have, at least on the child and youth side, we do have a provincial program that thinks about maternal care. We have, within the mental health world, and Paul can speak to that more, a little bit more governance around sort of what those relationships, and that's clearly kind of the way to go. So, and I think it'd be interesting to hear from some of the policy people in the room too, from their perspective about how that can go a little bit better.
Just so people know, Astrid mentioned this concept of a learning health system, and there's for the past decade or so, there's been an emerging literature on this, and the idea behind it is that that a learning health system is one in which data are routinely generated through every patient or client or encounter. The data are usable in real time, feedback to both the client/patient and the provider. But if you look at the literature, it says as much about the culture that is required to enact the concepts of a learning health system, that you are receptive to feedback, that you use that feedback in constructive ways, and that you are all sort of motivated by the same principles of quality improvement around whatever it is you're working on. Like to me, what's really struck me about the Learning Health Center concept is that the cultural aspect of it, that I think we often think, well, we measured stuff, like, let's go. No, there's a huge cultural piece that goes to quality improvement and implementation. Any other comments from the audience or any reaction from the panel?
If you wait long enough, sometimes those people within the ministry ever circle back again.
Well, and it's actually not a failure, because what's actually happening, whether it's people you're engaging with in practice or in policy, is the more people are moving around, first of all, you get better at giving your spiel, you start to understand what people already know and what they don't know, which is really important, but also they end up working in other parts of our province sometimes, or even in other provinces. Like, we're just building knowledge with more people. It's not a loss, actually, it's an expansion.
I think Anna?
So I resemble that remark, and I just want to say that I think that there is probably some justifiable frustration and impatience, but I do want to say that this data and this scorecard has already influenced macro policy significantly. If you look at the direction towards structured psychotherapy, if you look at the Leadership Advisory Council, I know that the final report hasn't come out, but this data has directly informed those recommendations. That is the vehicle we have now. There is a need for ongoing governance, I don't discount that, but I just think we should be, just be cognizant how much having this data has made a difference. And there's a lot more that needs to happen, and I agree with Astrid, there's the policy level, there's the frontline level, but I just think that with the absence of this data, we probably wouldn't have gone that distance.
Yeah, and so, like I said at the beginning, these days are a moment for reflection, and
Yeah.
we have come a long way as a sector in a very short time. But I think what we're experiencing is that, especially with the nature of the information we're unearthing, there's an impatience to do more.
Yes. And that's commendable.
At the back, I think it was.
So I'm Catherine Williams. I'm board chair for a company called Keystone Child, Youth and Family Services. We're in Lone Sound. And just to Dr. Vigod, we run a program called Cradle Link, for anybody who may have heard of it, and I'm a volunteer for it. So it's professional nurses run it, and volunteers are the ones who do a lot of the legwork, but it's for new moms, new dads, and it's available to anyone in Bruce and Grey counties. So you can be a mom who has mental health problems. You can be a mom who is perfectly fine, but it's somebody who comes into the home, helps with baby, mom can have a shower, mom can go to sleep, we go grocery shopping together, we can go shopping, we can do anything, but it's there to have someone lending a hand. And so I do it for free every week. And it's just, it's just one of those things that is out there, and part of why I came today is, this is looking at the, the people who are 60 and older, and we look after the 0 to 17. But part of things like Cradle Link is people say, well, why do you offer it to people who don't have any problems? Exactly. So they don't have problems down the road. So I'm here today to sort of learn what's the research about the, the children and the adults who maybe didn't get into help or a system, and what can we still be doing to help prevent them from becoming some of your stats.
One of the interesting things that I viewed, particularly around the child and youth strategy work that we did, because I was really unfamiliar with that sector, and I think the same is true in the adult sector, is that just the availability of resources does not automatically result in efficiency. And what I mean by that is, I would see, we mapped where resources were, and to no surprise, there were a ton of resources in the Toronto Central End, and there would often be very few resources. But when you started hearing stories from when Julie was going around, we were, getting people to describe their sort of the information we needed to construct our logic models. But it was kind of the narrative. Like in these areas, like in Owen Sound, you're much more likely to sit across the table with people from the different sectors. And in Toronto, that never happens. That we stay within our own silos because we don't there are enough of us in each sector. So I just think that that really struck me, getting back to this relational piece, the ability to look a person across the table and be solution oriented around an issue versus staying within your own camp and trying to figure things out on your own. That occurs across the province independent of availability, or even inversely related to the amount of resources that are available, which I found really, really interesting. I don't know if that resonates. I see Gail nodding from the addiction sector, but does that, that just was my perception. I don't know if that's actually accurate.
So I'm Ellen Tulaney. from Sick Kids and the Center for Quality Improvement and Patient Safety. So I think one of the barriers that hasn't been mentioned thus far is when we talk about implementation, and we talk about the cultural changes and the iterative change cycles that are needed, we can't just expect frontline clinicians to know how to do this. There is a process, there is a science for quality improvement, and there isn't, in my opinion, capacity to implement without champions at each of these sites who have been trained in these methods and can lead a team. So a lot of what you're saying resonates with me, and I think that may be a barrier that we should be looking at.
Right, and what do we do when champions have to span sectors?
So this is Gail from Addictions and Mental Health Ontario, and we span both addictions and mental health, but that comment about the need for support for capacity building and quality improvement is currently being addressed by the EQUIP program, the Excellence in Quality Improvement Program, that we are we're working with CMHA Ontario and HQO to implement across the province in the community to increase that capacity, create that culture for receptivity and implementation of quality improvement, and that's really important. But as you've been saying, Paul, there are a couple of challenges. One is if you just look at the challenge within CAMH at spreading best practices, and you've got a relatively closed system there and a relatively consistent way of measuring, assessing people's needs so that there can be agreement at least on what the problem is that you're trying to solve together, and yet it's still hard to get people to solve that in a best practice kind of way. It's not surprising that when you try to cross sectors, which is the mark of the complex client, there's going to be additional challenges. So I think we just keep at it, and we just need to keep building the capacity to do that across the system, but we need to build it, I would suggest, maybe I'll be a little bit controversial, even more in the community side, because in order to create that receptivity, you need to have the expertise, you need to have the champions and so on, and there's really no motivation. Motivation sounds personal, but I've looked for a number of months at how we can implement the research that's needed both for basic research and implementation in the community sector, and we can't do that. We don't have the infrastructure or the reward system that exists in other parts of the system, so I think that's a big problem. How do we create that on the community side so that those leaders in the community have access to those same kinds of expertise and implementation supports?
I mean, this is going to be a little bit tangential, but I'm thinking about this very broadly and thinking about what you're saying. There's really good evidence that simply measuring people's outcomes, simply measuring how they do after a course of care, whether you're just doing that clinically, I'm talking about, or or part of a research study or whatever, improves people's outcomes. And if we take, let's say, diabetes as an example, you could take a marker of how well diabetes care is being delivered by looking at someone's hemoglobin A1C or by measuring their sugars, right? And then you could build reward systems around how well the interventions that are delivered do that. I think probably a lot of us think about how we would apply that to mental health, and it's really complicated because what on earth measure do you use? Is it a symptom? Is it a function? Is it a readmission? And I think, I just wanted to raise that. I think that's partly what you're talking about. It is probably something that we could do, and then we could see if it improved things. I think we're still at a thinking stage of how we would do that in the best way possible.
So we did one study related to transitional discharge where we implemented on 42 wards across the province. We did it in 3 waves. where the first wave would make recommendations for implementation to the second wave, and then the second wave made recommendations to the third wave, which really worked. So by the time we got to the third wave, people at the beginning, because they were randomized, were really upset being in wave 3, but they actually got the best because they were able to implement the most quickly. The key thing actually was exactly what you were saying around identifying champions on each area for the actual implementation. The other thing that was extremely important was the way the staff engagement and training happened. We had the best results when it happened with everyone at once and quickly. In this phase 1, we had done it where, for example, with the nursing staff, with the shift rotations, they ended up being way behind getting all the nursing staff through learning about it compared to the other members of the interdisciplinary team. And so there ended up being this lag, whereas in the second and third round, we did it, pulled people off, backfilled positions, and just made sure that we had like a kind of retreat where within 1 or 2 half days we could get everybody on the same page. Had a huge impact in how quickly we could implement and how quickly we saw the positive results. So from a cost perspective, it ended up being much more cost effective, even though the backfilling, people don't like that idea, it would actually work the best. So those were the two main things, were the stakeholders and the getting everyone together quickly, getting that thing up and running fast. Interestingly, the other thing we found in each cycle, because I say you can imagine with 42 wards, we did find there sometimes were people that were trying to pull back and slow down or were hesitant about the implementation. So the biggest strategy to avoid implementation is what we called, and I'm sure you've all seen this, death by process. We are going to look at it. We just need 1 or 2 more committee meetings to discuss this. And this was basically the kiss of death. So that any time where that kind of where the focus what was moved too far from the action, we found it was very difficult. And in fact, in most of those areas, we didn't see a switch until we saw a new champion emerge. But that was very interesting, 42 wards, and seeing these similarities across. And we had measures that looked at degree of implementation, so we were able to look at these process issues and then line them up with what was actually happening in terms of the outcome and the actual implementation. So it was quite interesting.
Any other comments? So it's 11:30. I want to maybe we'll wrap things up. I want to thank the panel for spending their time sharing their insights and just really interesting different stories about trying to do kind of research. So thank you very much for